Hey there, test coming up on Cluster A personality disorders. I have 19 practice questions for you. Ready? Let's learn psych fast. Question 1. Which of the following is not a characteristic feature of schizotypal personality disorder? Is it A, social withdrawal, B, odd belief or magical thinking, C, lack of desire for close relationships, or is it D, grandiose sense of self-importance? The answer is A, social withdrawal. In schizotypal personality disorder, individuals often experience social withdrawal as they tend to feel anxious or uncomfortable in social situations. They may have peculiar behaviors or odd belief that make it challenging for them to connect with others. This social withdrawal contributes to their difficulty in forming and maintaining close relationships, which is a key characteristic of schizotypal personality disorder. So let's look at the other options that were incorrect and why they were. Option B, odd belief or magical thinking. Well, while odd beliefs or magical thinking are indeed characteristic of schizotypal personality, they are not the defining feature being asked for in this question. C, lack of desire for close relationships. This option might seem plausible, but it's not entirely accurate. Individuals with schizotypal personality disorder may desire close relationships, but their odd behaviors and social anxiety often make it challenging for them to establish and maintain such relationships. So it's not like a lack of desire per se, but rather difficulty in fulfilling the desire due to their symptoms. Option D, grandiose sense of self-importance. This choice aligns actually more so with the traits associated in cluster B personality disorders, such as narcissistic personality disorder. It's not a characteristic of the schizotypal personality, which tends to involve more the eccentric behavior and social withdrawal rather than grandiosity. So in summary, option A is the correct answer because social withdrawal is a prominent feature of schizotypal personality disorder, whereas the other options either describe features more typical of other personality disorders or they do not accurately reflect the primary characteristic being asked for in the question. Question 2. Patients with paranoid personality disorder distrust others and assume that others tend to harm or deceive them, even though they have sufficient justification for these feelings. The estimated median prevalence of this disorder is 3.2%. It is most common in which of the following patient populations? A, adolescent boys, B, adolescent girls, C, adult men, or D, adult women. The answer is C. Symptoms and signs of PPD typically start in early adulthood, and this condition primarily affects men, so that makes the other options incorrect. Question 3. Individuals with schizoid PD typically exhibit A, eccentric behavior and odd speech patterns, B, disregard and violation of rights of others, C, detachment from social relationships and a limited range of emotions, or is it D, instability in interpersonal relationships, self-image, and emotions? The answer is C, detachment from social relationships and a limited range of emotions. Yep, so that's really the one. That is schizoid PD. They tend to keep to themselves. They prefer solitary activities and don't really feel the need to make close relationships and connections with others. Plus, they often seem emotionally distant or even cold. Now, let's look at the other options to see why they were incorrect. A, eccentric behavior and odd speech patterns. While it might seem like folks with schizoid PD would act eccentrically, that's more in line with schizotypal PD. Schizoid individuals are more about keeping to themselves and standing out in a quirky way. Option B, disregard for and violation of rights of others. This one sounds more like antisocial PD, where people consistently ignore or trample over their rights of others. But for schizoid PD, it's more about not really engaging with others in the first place. And then option D, instability in interpersonal relationships, self-image, and emotions. This option is all about the ups and downs of emotions and relationships, which rings truer to which one? Borderline PD. People with schizoid PD tend to be more emotionally steady and don't have roller coaster like relationships and dramas. Question 4. Paranoid PD is characterized by what? A. Disregard for and violation of the rights of others. B. Fear of abandonment and efforts to avoid real or imagined abandonment. C. Pervasive distrust and suspicion of others without sufficient bias. Or is it D. Excessive emotionality and attention-seeking behavior? The answer is C, pervasive distrust and suspicion of others without sufficient bias. So that's spot on paranoid PD. It's all about seeing threats where there might not even be one that exists. People with this disorder tend to be extremely suspicious of others, always thinking that people are out to get them or harm them, even when there's no real evidence for it. Now let's dive into why the other options aren't quite right. A, disregard for and violation of rights of others. This one sounds more like antisocial PD, where people consistently ignore or trample over the rights of others. But for paranoid PD, it's more about the intense distrust and suspicion rather than the disregard for others' rights. B, fear of abandonment and effort to avoid real or imagined abandonment. While fear of abandonment is a big deal in some personality disorders like borderline PD, it's not the main one for paranoid PD. Instead, it's all about suspicion and distrust. And then D, excessive emotionality and attention-seeking behavior. This option seems to be more in line with histrionic PD, where people crave attention and can be very emotional. But for paranoid PD, it's more about being suspicious and guarded than attention-seeking. So option C, of course, here is the winner because it captures the core feature of paranoid PD, that pervasive, unwavering distrust and suspicion of others, even when there's no good reason for it. The other options might fit better with other personality disorders. Question 5. Which of the following is a common feature of both schizotypal PD and schizoid PD? A, profound discomfort in close relationships. B, pronounced disregard for law and the rights of others. C, extreme attention-seeking behavior. D, chaotic and unstable relationships. The answer is A, profound discomfort in close relationships. You got it. Both schizotypal personality and schizoid PD involve both significant discomfort in forming and maintaining close relationships. Individuals with these disorders often prefer solitude and struggle to connect with others on a deep emotional level due to their unique personality traits. Now let's explore why the other options miss the mark. B, pronounced disregard for law and the rights of others. This choice is more indicative of traits associated with antisocial PD, where individuals consistently disregard and violate the rights of others without remorse. It's not a characteristic feature of schizoid typical or schizoid. C, extreme attention-seeking behavior. This option seems more in line with histrionic PD, where the individual craves attention and may engage in dramatic or flamboyant behaviors to achieve it. It's not a common feature of schizotypal or schizoid, which tend to involve what? Social withdrawal rather than attention-seeking. The last one, D, chaotic and unstable relationships. No, this is characteristic with borderline PD, where individuals struggle with instability in relationship. It's not typically associated with schizotypal or schizoid PDs, which tend to involve difficulty in forming relationships rather than the instability in existing ones. So option A, of course, then is correct, the answer. It accurately identifies common features of both schizotypal and schizoid PDs. Profound discomfort in close relationships. The other options definitely fit better in other personality disorders than in this one. Question 6. Individuals with schizotypal PD may experience transient psychotic episodes characterized by A, delusions of grandeur, B, hallucinations and disorganized speech, C, impulsivity and recklessness, D, excessive preoccupation with orderliness and perfectionism. The answer is B, hallucinations and disorganized speech. Transient psychotic episodes of schizotypal PD can indeed involve hallucinations and disorganized speech. These episodes are typically brief and may be accompanied by unusual beliefs or magical thinking. So let's go over why the others are incorrect. A, delusions of grandeur. While delusions are common in psychotic episodes, delusions of grandeur, though, are more characteristics of disorder of bipolar disorder, with the psychotic features of schizoaffective disorder. C is impulsivity and recklessness. This option aligns more with symptoms seen in borderline PD, where individuals may engage in impulse and reckless behaviors. It's not typically associated with the psychotic episodes of schizotypal PD, which is more characterized by hallucinations and disorganized thinking. And option D, excessive preoccupation with orderliness and perfectionism. This choice is more indicative of obsessive compulsive personality disorder, where individuals are excessively preoccupied with perfectionism. Question 7. A hallmark feature of schizotypal personality disorder is A, avoidance of social situations and relationships, B, disregard for safety and rights of others, C, odd belief or magical thinking, D, instability in self-image, interpersonal relationships, and affect. The answer is C, odd beliefs or magical thinking. This is brought up on the last question. One of the hallmark features of schizotypal PD is indeed odd beliefs or magical thinking. Individuals with this disorder may hold beliefs that seem unusual or bizarre to others, such as superstitions or beliefs in psychic abilities. This type of thinking is a key characteristic of schizotypal PD and contributes to the eccentricities often observed in the affected individual. So why are the others wrong? A, avoidance of social situations or in relationships. While individuals with schizotypal PD may indeed experience social difficulties, such as discomfort in social situations or limited close relationships, this is not the hallmark feature being asked for in the question. B, disregard for safety and rights of others. This trait aligns more with antisocial PD, where the individual consistently disregard and violate the rights of others without remorse. It's not a characteristic of schizotypal PD, which is primarily involves what? Odd beliefs and social eccentricities. D, instability in self-image, interpersonal relations, and affect. This option describes features typically seen in borderline PD, where individuals struggle with instability in relationships, self-image, and emotions. While individuals with schizotypal PD may have difficulties in interpersonal relationships, their instability is more related to eccentric behaviors and odd beliefs rather than the emotional instability seen in borderline. So option C is the correct answer here because it accurately identifies a hallmark feature of schizotypal belief, which is odd beliefs or magical thinking. The other options fit other personality disorders. Question 9. Schizoid personality disorders characterized by what? A, pervasive patterns of disregard for and violation of rights of others. B, eccentricities in behaviors and odd speech pattern. C, fear of abandonment and unstable interpersonal relationships. Or is it D, detachment from social relationships and limited emotional expression? The answer is D. This is spot on schizoid personality disorder. It's characterized by a marked detachment from social relationships. Individuals with this disorder tend to prefer solitude and have little interest in forming close relationships. Additionally, they often display limited emotional expression, appearing emotionally detached or indifferent in various situations. Now let's explore why the other options were not correct. A, pervasive patterns of disregard for and violation of rights of others. This choice is more indicative of traits associated with antisocial PD, where individuals consistently disregard and violate the rights of others without remorse. It's not a characteristic of schizoid. B, eccentricities in behavior and odd speech pattern. Well, eccentric behavior and odd speech pattern are more characteristic of schizotypal PD, not schizoid PD. And then C, fear of abandonment and unstable interpersonal relationship. This option seems to be more in line with the traits of borderline PD, where individuals struggle with fear of abandonment and exhibit instability in interpersonal relationships. Question 9. Pharmacological treatment of schizoid personality disorder often focuses on addressing what? Is it A, social anxiety symptoms, B, negative symptoms of schizophrenia, C, depressive symptoms, or D, impulsive behavior? The answer is B, negative symptoms of schizophrenia. Pharmacological treatment for schizoid personality disorder often revolves around managing the negative symptoms such as apathy, social withdrawal, and emotional blunting. These symptoms bear resemblance to the negative symptoms observed in schizophrenia, and medications targeting them can potentially improve the individual's overall functioning and quality of life. Now let's look to see why the others were wrong. A, social anxiety symptoms. While individuals with schizoid PD may experience social anxiety symptoms in certain situations, pharmacological treatment typically doesn't directly target social anxiety symptoms as the primary focus. These individuals often prefer solitude rather than seeking treatment for social anxiety. C, depressive symptoms. While depression can co-occur with schizoid PD, pharmacologic treatment primarily targets depressive symptoms, may not effectively address the core features of schizoid PD, such as their social detachment and limited emotional expression. And option D, impulse behaviors. Well, schizoid PD is typically not associated with impulsive behaviors, which are more characteristics of other personality disorders like borderline PD. Pharmacological treatment target impulsive behaviors would be less relevant for individuals with schizoid PD. Question 10. When considering pharmacological treatment for schizotypal disorders, which class of medications is often considered first line due to its potential to mitigate psychotic-like symptoms? Is it A, SSRIs, B, antipsychotics, C, mood stabilizers, or D, benzos? The answer is B, antipsychotics. Antipsychotics are frequently considered first-line medications addressing psychotic-like symptoms in schizotypal PD. These symptoms can include perceptual disturbance, odd beliefs, and suspiciousness, which may respond well to antipsychotic medications by reducing their intensity and frequency. So let's review the others of why they're wrong. SSRIs, option A. While SSRIs may be helpful for managing comorbid depression or anxiety symptoms in individuals with schizoid PD, they're typically not the first line of choice directly to treat psychotic-like symptoms. C, mood stabilizers. While mood stabilizers might be considered in certain cases, particularly if there's co-occurring mood symptoms or if there's a concern about impulsivity or affective instability, but they're not typically the first line of choice for mitigating psychotic-like symptoms. And then benzos are primarily used to manage symptoms of anxiety or insomnia and are not typically indicated for directly addressing that psychotic-like symptoms that are seen in schizotypal PD. Question 11. Which of the following therapeutic interventions is commonly employed to address the social isolation and interpersonal difficulties experienced by individuals with schizoid PD? Is it A, group therapy, B, exposure therapy, C, reality therapy disorder, or D, gestalt therapy? The answer is A, group therapy. So group therapy is often utilized to address social isolation and interpersonal difficulties faced by individuals with schizoid PD. Group settings provide a supportive environment where individuals can gradually learn and practice social skills, receiving feedback from their peers, and develop connection with others in a structured but safe manner. All right, let's go over the wrong answers. B, exposure therapy. Exposure therapy is typically used to treat anxiety disorders by gradually exposing individuals to feared situations or stimuli in a controlled manner to reduce fear and avoidance. While it may have some applications in certain cases, it's typically not the first line of choice for addressing the social isolation and interpersonal difficulties characteristic of schizoid PD. C, reality therapy. Reality therapy, that focuses on helping individuals take responsibility for their actions and choices to improve their present and future lives. While it may have some value in addressing certain aspects of personality disorder, it's not specifically tailored to address the social isolation and interpersonal difficulties seen in schizoid. And D, gestalt therapy, that emphasizes personal responsibility and awareness of one's experiences in the present moment. While it may be helpful for some individuals, it's not typically the primary choice for addressing the social isolation and interpersonal difficulties that are characteristic with schizoid PD. Question 13. In the treatment of cluster A personality disorder, psychoeducation is often an essential component of therapy. Which of the following topics is particularly pertinent to include in the psychoeducation sessions for individuals with these disorders? A, coping skills for managing mood swings. B, understanding and challenging distorted thought patterns. C, identifying and managing triggers or impulsive behavior. Or is it D, recognizing and addressing maladaptive interpersonal patterns? The answer is D. So psychoeducation plays a crucial role in the treatment of cluster A personality disorders, and recognizing and addressing maladaptive interpersonal patterns is particularly pertinent. Individuals with these disorders often struggle with forming and maintaining healthy relationships due to their unique personality traits. Psychoeducation can help them understand how their interpersonal patterns may contribute to relationship difficulties and provide them with strategies to address these patterns in a more adaptive manner. All right, let's go over the other options of why they're wrong. A, coping skills for managing mood swings. While coping skills are important in therapy, mood swings are not a primary characteristic of cluster A personality disorders. These disorders are more characterized by eccentric in behavior and social detachment and suspiciousness rather than mood instability. And B, understanding and challenging distorted thought patterns. Well, challenging distorted thought patterns is a common component of therapy, but it's not as directly relevant to cluster A PDs as recognizing and addressing maladaptive interpersonal patterns. These disorders are more associated with unusual beliefs, social detachment, and suspiciousness rather than distorted thinking. And option C, identifying and managing triggers for impulsive behaviors. Impulsive behaviors are more characteristics of personality disorders in cluster B, such as borderline PD. While identifying triggers and managing impulse may be important, it's not as directly relevant to individuals with cluster A PD who are more likely to struggle with social detachment and eccentricities in behavior. So option D is the correct answer because it accurately identifies and recognizes and addresses the maladaptive interpersonal patterns as a particularly pertinent topic to include in psychoeducation sessions for individuals with cluster A personality disorders. Question 13. In addition to pharmacotherapy, which therapeutic approach is commonly used to address social anxiety, cognitive distortions, and eccentric behaviors in individuals with schizotypal personality disorders? Is it A, psychodynamic therapy, B, DBT, C, psychodynamic therapy, or D, interpersonal therapy? So the correct answer here is C, cognitive behavioral therapy, CBT. Picture CBT, that's that Swiss Army knife of therapy. It's super versatile. It can tackle a variety of challenges. While schizotypal personality disorder, CBT steps in to help individuals recognize and challenge those funky thoughts and thought patterns and beliefs and cope with social anxiety and sharpen up their social skills. It's like a mental gym session, building a strength in areas where they've been a little bit of a mental stubble. Now, why are the others incorrect? A. Psychodynamic therapy. While psychodynamic therapy might dive deep into the psyche and explore past experiences, it's not typically the go-to for addressing the specific symptoms and quirky thinking patterns seen in schizotypal PD. Dialectical behavior therapy, DBT, it's like the expert in handling intense emotions, but it's not always the top pick for schizotypal. While it might help some symptoms, it's not tailored to tackle the social anxiety, cognitive quirks, and eccentric behaviors that are at the forefront of this disorder. And then D, interpersonal therapy. This therapy is all about relationships and communication, which are important, no doubt, but when it comes to schizotypal PD, it might not directly address those wacky thought patterns and eccentric behaviors that need a bit of fine-tuning. Question 14. Individuals with schizotypal PD often experience deficits in social skills and interpersonal functioning. Which therapeutic intervention is specifically designed to target these deficits and improve social competence? A. Group therapy, B. Exposure therapy, C. Reality therapy, or D. Psychodynamic therapy? The answer is A. Group therapy. All right, group therapy takes the spotlight here. It's like the social boot camp designed really well for those schizotypal PD patients. It beefs up their social skills and navigates the interpersonal interactions with much more finesse. Group therapy, it does provide that supportive environment where individuals can practice social skills, receive feedback from others, and gradually build confidence in their ability to engage with others. It's like a safe space to experiment with different social behaviors and learn from both successes and challenges. B, exposure therapy was incorrect. Exposure therapy is more commonly used to treat anxiety disorder by gradually exposing individuals to feared situations to reduce fear and avoidance. While it can be helpful for addressing specific fears and anxiety, it's not specifically tailored to target the broader deficits in social skills and interpersonal functioning seen in schizotypal PD. Reality therapy? Well, that focuses on helping individuals take responsibility for their actions and make choices to improve their present and future lives. While it can be valuable for personal growth, it doesn't directly address the deficits in social skills and interpersonal function characteristic of schizotypal PD. And then D, psychodynamic therapy. That explores unconscious conflicts and early life experiences, but it may not be directly focused on building social skills and improving interpersonal functioning in group therapy. Question 15. Which of the following is a key component of psychoeducation for individuals with schizotypal personality disorder? A. Coping skills for managing impulsivity. B. Recognizing and challenging distorted thought patterns. C. Identifying and managing triggers for anxiety attacks. Or is it D. Understand the role in genetics in personality development? The answer is D. Understand the role of genetics in personality development. All right, so understand the role of genetics in personality development takes center stage here. It's like unlocking the secrets of a person's blueprint, helping those individuals with schizotypal to gain insight into why they may have certain traits and tendencies. When we talk about psychoeducation for schizotypal PD, it's important to shed light on how genetics can shape personality traits and behaviors. By understanding that there's a biological bias for certain aspects of their personality, individuals can feel less stigmatized and more empowered to work on managing their symptoms. Let's go over the incorrect ones. A. Coping skills for managing impulsivity. While coping skills are important, impulsivity isn't typically a primary feature of schizotypal PD. Individuals with this disorder often struggle more with social detachment and eccentric thinking than impulsivity. B. Recognizing and challenging distorted thought patterns. Challenging distorted thought patterns is a common aspect of therapy, but it's not as directly relevant to the psychoeducation for the schizotypal PD. This disorder is more characteristic of what? That unusual belief and social detachment rather than distorted thinking. And then C. identifying and managing triggers for anxiety attacks. Anxiety attacks aren't a primary symptom of schizotypal PD. While individuals with this disorder may experience social anxiety, psychoeducation typically focuses on understanding the disorder itself rather than managing anxiety attacks. Question 16. Which of the following adjunctive interventions may be helpful in addressing co-occurring depressive symptoms in individuals with schizotypal personality disorder? Is it A, mindfulness meditation, B, electroconvulsive therapy, C, family therapy, or D, light therapy, also called phototherapy? The correct answer is A, mindfulness meditation. So that's the one that gets the nod here. So it's just like that wonderful mental spa that these individuals with schizotypal need. So mindfulness meditation has been shown to be beneficial for reducing symptoms of depression by promoting present moment awareness and acceptance of one's thoughts and feelings. It's like hitting the reset button on the mind, helping individuals step back from negative thoughts and emotions and find a bit of calm in the chaos. So why are the other options incorrect? B, electroconvulsive therapy. That's typically reserved for severe cases of depression that have not responded to other treatments. C, family therapy, that focuses on improving communication and resolving conflicts with family systems. While it can be beneficial for addressing rational dynamics, it may not directly target the individual depressive symptoms. And then D, light therapy, that's often used to treat seasonal affective disorder, a type of depression that occurs at specific times of the year. While it can be helpful for individuals with seasonal affect disorder, it may not be directly applicable to individuals with schizotypal. Question 17. Which therapeutic approach is commonly used to address social detachment and limited emotional expression in individuals with schizotypal PD? Is it A, dialectical behavior therapy, B, psychodynamic therapy, C, group therapy, or D, reality therapy? The answer is B, psychodynamic therapy. So psychodynamic therapy explores unconscious conflicts and early life experiences that may contribute to the development of maladaptive patterns of relating to others. By bringing these underlying dynamics to light, individuals can gain insight into their social detachment and emotional expressions and work towards making positive changes. Why are the others incorrect? A, DBT. While DBT is effective for conditions like borderline personality disorder, where emotional dysregulation is prominent, it may not be as tailored to directly address the social detachment and limited emotional expression characteristic of Schizoid PD. C, group therapy. Group therapy, it provides a supportive environment for individuals to practice social skills and receive feedback from their peers. While it can be beneficial in improving social functioning, it may not specifically target underlying emotional expressions seen in schizoid personality disorder. Then D, reality therapy. Reality therapy, it focuses on helping individuals take responsibility for their actions and make choices to improve their present and future lives. While it may be of value for personal growth, it may not directly address the social detachment and limited emotional expressions characteristic of schizoid PD. And last question, 18. Which class of medication may be considered as adjunctive therapy treatment for co-occurring symptoms such as depressive symptoms or anxiety in individuals with schizoid personality disorder? A, SSRI, B, antipsychotic, C, benzos, or D, mood stabilizers? And the correct answer is A, SSRIs. All right, SSRIs, that certainly takes a spotlight here. They help mood boosting, help individuals with schizoid personality manage those pesky depressive symptoms or anxiety that often tag along with this disorder. So an SSRI like sertraline or fluoxetine, they work by increasing the serotonin levels in the brain, which can help alleviate symptoms of depression and anxiety. They're not just mood enhancers. They actually help individuals with schizoid PD cope better with emotional roller coaster that can come with the disorder. Option B, antipsychotics, was incorrect. While antipsychotics, they may help address the psychotic-like symptoms in individuals with schizoid PD, they're not typically the first choice for treating co-occurrent depression symptoms or anxiety. Antipsychotics primarily target symptoms such as perceptual disturbances and paranoia. C, benzos. Benzos like diazepam and alprazolam are often used to treat acute anxiety symptoms due to their sedative properties. However, they're not usually recommended for long-term treatment for co-recurrent depressive symptoms in individuals with schizoid PD due to the risk of dependence and cognitive impairment. And then D, mood stabilizers. Mood stabilizers such as lithium or valproate are commonly used to treat mood disorders like bipolar disorder to stabilize mood fluctuations. While they may have some utility in certain cases, they're not typically the first choice for treating co-occurrent depressive symptoms or anxiety in individuals with schizoid PD. So SSRIs, option A, definitely steals the spotlight here. They are specifically tailored to address depressive symptoms or anxiety that occur with schizoid PD. All right, so you finished cluster A. Now let's go to cluster B. Click on this video right here.